Hello, everyone. My name is Nadia Ali. I'm the director of the Center for Middle East Studies here at Brown University, and my pleasure to introduce you to today's event on access to abortion in the Middle East and North Africa. The event today has been co-organized by the Center for Middle East Studies and Masters in Public Affairs candidate Nargis Jafarian. We will explore access to abortion in different parts of the Arab majority world, the intersectionality of access for married and unmarried women, the interplay of class and access to abortion, and how women have sought to access abortion in the face of different barriers and restrictions that are imposed on abortion in the respective countries that we're going to discuss in greater details. So I should also say that the event today is co-sponsored with the School of Public Health in recognition of National Public Health Week. Now, let me introduce my co-host, Nargis Jafarian. Nargis is pursuing her Masters of Public Affairs at Brown University. Through her program, she focuses on both national security and humanitarian interventions. Born and raised in the Middle East, she is passionate about highlighting the nuances in the region, particularly in areas related to gender-based policies and social development. And Nargis has a fellowship with the Center for Middle East Studies, and as part of this fellowship, she has been working with me on reproductive rights in the region. Welcome, Nargis. Over to you.
Thank you, Dr. Al-Ali. It gives me great pleasure to introduce our panelists today. They're covering such a great depth in different countries. First, we have Dr. Samia Nagar. She's an independent researcher. She's worked as a part-time lecturer at the Regional Institute for Gender Diversity, Peace and Rights, and the Ahfad University for Women during 1996 to 2019. Since 2012, she's been the lead researcher in a collaborative project with the Carl-Michelsen Institute, CMI Norway. Dr. Nagar has published extensively on women and conflict in Sudan, women's rights reform, women's movement in Sudan. She wrote papers on critical issues such as female genital mutilation, gender-based violence, child marriage, and abortion. As a Sudanese national, she's active in Mansam, a feminist coalition established in the wake of the Sudanese revolution in 2019. We also have with us Dr. Zeina Fathallah from the American University of Beirut. Dr. Fathallah is a lecturer in sociology at AUB. She holds a specialized degree in economics and health studies and health systems management from the University of Paris, and a Master's of Public Health with a concentration in health education from San Jose State University. She's completed her PhD in sociology in 2011. I am not very good at pronouncing the name, from EDHESS. In her dissertation, Moral Work and Construction of Abortion Networks, Health and Sexuality of Women in Lebanon, she explored using both sociological and ethnographic approaches to the intersectional effects of criminalization of women's access to safe abortion in Lebanon. And finally, we also have Dr. Angel Foster. She's from the Faculty of Health and Sciences of the University of Ottawa. Dr. Foster is a professor in the Faculty of Health and Sciences. She holds a doctorate from the University of Oxford in Middle Eastern Studies, an MD from Harvard Medical School, and both her master's and bachelor's degrees from Stanford University. She's a global abortion researcher. She leads projects in 22 countries. She's authored more than 100 articles and co-edited 3 books. Dr. Foster is also the chair of the board of directors of the National Abortion Federation Canada, and as the co-chair of the Safe Abortion Care Sub-Working Group of the Interagency Working Group on Reproductive Health in Crises. In 2011, she received the Guttmacher Institute Derek Award for Excellence in Sexual Reproductive Health Research. Welcome our panelists. I invite you to turn on your cameras as I hand it off to Dr. Al-Ali to get us kicked off.
Yeah, thank you very much, Nargis. So just to let everyone know about the structure of today's event, Nargis and myself will be in conversation with our guest today. And we invite you to put your comments or questions in the Q&A function of the webinar, and we will have time towards the end of the session to engage in Q&A. So we thought that it would be a good idea to start out asking everyone to reflect for a few minutes on the specific conditions regarding abortion, access to abortion in the respective countries that they cover. And to that extent, I'd like to start out with Dr. Samia Nagar and ask her about the situation in the Sudan. Samia?
Okay, hello everybody, and thank you for this opportunity. And because it's one of the very few opportunities where we can talk about such very taboo issues, abortion. We don't talk about it very much in Sudan, although we did some research. But let me first say that this work is done jointly with Dr. Leif Tonnesson from the CMI, Bergen, and it is part of a project called Determinants of Sexual and Reproductive Health Criminalization, Health Impacts and Game Changes, which has been on from 2016 to 2022. The project covered several countries, including Sudan, from North Africa, including Sudan and Tunisia. First, let me start very quickly. Why are we interested in abortion? And I think that it's very important, though we are not talking about it, but it is really a problem. It is a gender issue. It is women issue because it has been really increasing, although there is no data, but there are indicators that it has been increasing. The very few studies has shown that it has been it is one of the factors causing maternal mortality and morbidity. And we have in Sudan very high rate of maternal mortality, and this is really a problem, but it has not been taken as one of the factors which contributes to maternal mortality. But one of the studies shows that 97% of the women who come to seek abortion, they come with post-abortion complications. They don't come to seek because in Sudan, abortion is illegal. It is not. It's not allowed. It is not. There is no access to it except in very few situations, and that is when the woman is at risk, when the fetus dies in her womb, or when a woman has pregnancy after rape. This is the only two situations when a woman is allowed. And these are the first are for married women. Unmarried women have no access. Legally, they are considered as in a crime. It is called illegal. They are considered as having illegal pregnancy, not abortion, but illegal pregnancy, and that is an issue. There is no access, as I said, because of this legal restriction. But for mothers, if they come in the first trimesters, they can have access to abortion in the public hospitals. But for young women who are not married, they are not allowed. And they are not allowed to come. And that is why they do not come. And if they come with the complications. And there is, in the public hospitals, there are police who watch, and there are some bureaucratic barriers. They have to present a marriage certificate, and if they don't have a marriage certificate, then they are considered to have they are in a difficult situation. Another issue is that they may not find the services until the investigation is done. This is for the young unmarried women, and the doctors give them the care, but they may be taken immediately to prison. Abortion for us in Sudan, as an Islamist country, it is socially it stigmatized the young woman, and because virginity value is very high, and therefore most of the young girls who get pregnant, they go to the traditional methods of abortion, and that is why they come to hospitals with post-abortion complication or incomplete abortion, and this is very risky, and many of them may die. Although we don't have, although the Ministry of Health does not give any information on that. For some time, because for the high mortality, they thought of misoprostol as an alternative to be given to midwives to help reduce the risks for women during maternal labor and this, but then it was stopped because they were afraid that the midwives may misuse the misoprostol, so it is no more an alternative. For rape, for women rape, there are also a lot of problems, because most of the women who are raped, they report very late, although they cannot get access to abortion without having a reporting form called Form 8, which is filled by the police and by the doctor who receive them after the rape. And they come usually very late, and they lose all the evidence of being raped. And most of them, when they keep silence, they get pregnant, and then they are in a problem, and they are considered as having the crime of illegal pregnancy and adultery. And that is really a problem. We have some international organizations providing the emergency contraceptives for raped women, but this is not accessible. It's accessible only mainly in the conflict areas, and it has to be managed by senior doctors. And therefore, most of the women who are raped do not get access to it, and they end up as being illegally pregnant. And therefore, most of unmarried women are at risk of unsafe abortion, and they use the traditional methods using herbs, tools, and these different means which put them at risk. Doctors usually do give the care to any woman, married and unmarried, who come to the hospitals. They don't care about the marriage certificate or anything, but this put the doctors at risk. They put the doctors at risk. But in all public hospitals, the police is there, and they come and ask for the marriage certificate. And
Dr. Samia, sorry, would you mind, I mean, we will follow up. Would you mind in this first instance to try to come to a conclusion so we can move?
Yeah, I'm coming to a conclusion. My last point is that as activists, there is a network for reproductive and sexual rights, and the concern for abortion is mainly by young women, but most of the women movement and feminist movement activists, they are not concerned about abortion because they are really afraid to be stigmatized religiously and socially. But I think that it's now time to come out with very loud voice, and we need to talk about abortion. Thank you very much.
Thank you very much, Dr. Samia. Yeah, I mean, I hope that in the discussion we can sort of look a little bit at the way how Islam, or sort of a religious justification, has actually sort of shifted. I mean, you know, different historical moments, and in different countries that are majority Muslim, there have been different approaches towards abortion, but it's certainly one way that anti-abortion campaigns or policies have been justified in the region. Thank you very much. So I'm now going to ask Dr. Foster to present us with her insights in relation to Tunisia in the first instance, although we know that you have worked in many different countries in the region, but it would be great if you could start, and you said you might also refer a little bit to the UAE. Over to you.
Great. Well, good morning, good afternoon, and good evening, everyone. My name is Angel Foster. My pronouns are she, her, hers, or anything respectful. My institutional home is the University of Ottawa, and I want to acknowledge that it stands on the traditional unceded territory of the Algonquin people. So I'm thrilled to have the opportunity to be on this panel. The issue of abortion is usually not the focus of discussion in Middle Eastern studies. I'm a global abortion researcher, and I've been working in the Middle East for over 30 years. And as noted in the introduction, I'm also a medical doctor as well as a researcher. And over the last 2 decades, I've worked with colleagues throughout the region to train health service providers and physicians in particular to provide abortion care. And although my own experience centers on the Arab world, my research group has also done work in other countries in the region, including Turkey, Iran, and Afghanistan. So I'm very excited to have kind of a wide-ranging discussion today. At the outset, I wanted to make a note about language. Any person who can become pregnant and sustain a pregnancy is someone who has an abortion. This is not limited to any specific gender identification. However, the vast majority of people who have abortions identify as women and girls. The overwhelming majority of clinical, public health, and social science research on abortion has focused specifically on women. And in many cases, the laws that criminalize abortion specifically target women, are constructed around gender binaries, and are rooted in patriarchy and colonization. And so today I'm going to use both gender inclusive and gendered language depending on context. To foreground the discussion, I think it's important to recognize that abortion is incredibly common. So each year, approximately 56 million abortions occur worldwide, and about 25 million abortions occur in what we call legally restricted settings. That is where abortion is prohibited for many or most reasons in the first trimester of pregnancy. But the legality of abortion does not correlate strongly with the abortion rate, and most unsafe abortions take place in countries where abortion is illegal, severely restricted, or inaccessible. Unsafe abortion practices have enormous health consequences and account for about 8 to 18% of maternal death each year. Unsafe abortion also contributes to considerable maternal morbidity. So about 7 million women seek treatment from unsafe abortions each year, and about 10 million women experience complications and do not seek treatment. Of course, restrictive abortion laws do not impact all people equally. Poor, marginalized, and minoritized women, whatever that means in a particular context, bear the burden of unsafe abortion. And because abortion is often illegal, illicit, or stigmatized, these are likely gross underestimates. So the big take-home message here is that abortion is common. On average, 1 abortion per woman over the course of their reproductive lives. Women all over the world have abortions, and laws criminalizing abortion make abortions unsafe, but do not eliminate them. So as it's going to be evident from this panel, the legal status of abortion varies considerably across the Arab world. And in Tunisia, first trimester abortion is legal and provided by the public sector, whereas in Yemen and the UAE, abortion is prohibited in almost all circumstances. However, throughout the region, unmet family planning needs, changing premarital sexual behaviors, contraceptive failure, and sexual violence place both married and unmarried women at significant risk of unintended pregnancy. And the limited information that we have suggests that the abortion rate in the Middle East and North Africa region is right around the global average of 28 abortions per 1,000 women of reproductive age. And the same global trends apply in the Middle East and North Africa region. Namely, restrictive abortion laws do not correlate strongly with abortion rates. And in the Arab world, about 15% of maternal death is directly attributable to unsafe abortion, and unsafe abortion is one of the leading causes of secondary infertility in the region. But I'm actually going to spend the remainder of my opening remarks talking specifically about Tunisia, which is an exceptional country within the region, but has also been a global leader in the public sector provision of abortion care. So as I'm sure many of you know, Tunisia gained independence from France in 1956, and the government immediately embarked on a series of revolutionary legal reforms. That included the reformation of personal status law and the codification of women's educational and professional rights and opportunities. But there was widespread recognition at the time that women in Tunisia would not be able to fully exercise their political, economic, or educational rights if they did not have reproductive control and autonomy. So in 1961, the Tunisian government introduced the first family planning program in Africa, and the legalization of abortion soon followed. First in a limited way in 1965, and then in 1973, the penal code was amended such that abortion became legal without restriction as to reason, marital status, or age throughout the first trimester. In an effort to minimize potential opposition, then President Habib Bourguiba included the announcement in a broader speech reaffirming the government's commitment to family planning and emphasized the compatibility of the law with Islamic principles. So in September of 1973, President Bourguiba announced the liberalization of the abortion law on the steps of the holiest mosque in Tunisia on the Prophet Muhammad's birthday, surrounded by Islamic jurists drawing from the Hanafi legal tradition. And to demonstrate the government's continued prioritization of family planning, that same year, the Tunisian government created the Office National de la Famille et la Population, or the ONFP, which is an autonomous subdivision of the Ministry of Public Health dedicated to reproductive health. Tunisia's first woman physician, a vocal proponent of legal abortion and herself a provider of abortion care, was appointed the first director of the ONFP, which is to this day a cabinet level position. So in the same 50-year period that the battles have raged in the United States, for example, around abortion, abortion has not really been a political issue in Tunisia. Indeed, abortion is generally viewed as a medical and public health issue, an integral part of the women's health program, and in turn, as a vital component to overall economic and human resource development. Tunisia continues to have the safest and most comprehensive abortion service in the region. Care is largely provided by professional midwives. And in 2001, Tunisia introduced medication abortion with the mifepristone-misoprostol regimen into the National Women's Health Program. Tunisian physicians actually participated in some of the world's first clinical trials related to medication abortion. And as of 2019, about 85% of all abortions in the country were with mifepristone and misoprostol. In Tunisia, about 1 in 11 pregnancies is terminated, and unsafe abortion is extraordinarily rare, and there's basically no maternal death related to abortion. So I've spent much of my academic and professional career arguing that the legalization and accessibility of abortion has had an enormous impact on women's health and women's opportunities within the country, and is one of the explanatory variables for why Tunisia's health indicators are consistently among the best in the region. And the trajectory of Tunisia is one that doesn't really fit neatly into popular conceptualizations of the Arab world or of Muslim majority countries, but it does represent a model for how abortion can become fully integrated into the public health sector, particularly in a lower middle income country and in a non-oil exporting economy. In our discussion, I'm happy to talk more about what's happened with reproductive health in the years since the 2011 revolution, but suffice it to say that even after the election of an Islamic government, no laws or policies which were enacted restricting abortion. I'll just end by saying that Tunisia is exceptional and represents what is possible. But in our broader discussion, I'm happy to talk more about some of the other cases, Egypt, Jordan, Palestine, and the UAE, where legal restrictions really do restrict service availability and where there are clear avenues by which access to safer services could be expanded and improved. So thank you, and I look forward to the discussion.
Thank you very much. Yeah, I think that although our focus is on access to reproductive health, abortion specifically, but in terms of, the overall aim of the Center for Middle East Studies is to also contribute to attempts to de-exceptionalize the Middle East. And I think the example of Tunisia is an excellent example. I mean, I think the example of the US is also an excellent example of how it's just not possible anymore to attach women's rights, with the West unquestioningly. And I guess what we see is that societies everywhere are actually quite polarized around issues linked to gender-based equality and also abortion as one example of reproductive rights. But now let me move on to Dr. Zeina Fathallah. And Dr. Zeina, you will tell us about the Lebanese context.
Thank you. Yes, hi everyone. Thank you, Najee. Thank you, Nargis, for inviting me to participate in this panel. I will share my PowerPoint. Is it?
Yes, you just have to put it in presentation mode. You know, here, if you go down, if you look next to notes, comments, and then there is a little sign.
Well, let me.
Well, if it doesn't work, or if you go to view above and then.
Let me check. Okay. More.
Yeah, if you don't manage, it's fine.
Okay, let me check another time. Share. Share. Okay, I have the share screen.
Go ahead and share the screen.
Maybe.
You just did.
Yes.
Is it clear now? Is it?
And then if you go, so it's sharing your screen. If you go to the very top,
yes,
underneath Presentation Brown University, on that red box, you'll see Home, Insert, Design, Transitions. Click on Slideshow.
I cannot see.
Okay, I think it's okay. Let's just not spend more time.
Okay.
Let's just, sorry, it's okay.
So I'll read my, that's fine, I'll read them. So in Lebanon, okay, so in Lebanon, the Lebanese Penal Code is established in 1943, prohibits abortion under all circumstances and bans the selling of substances used to induce abortion. And a woman having an abortion is subject to imprisonment of 6 months to 3 years. And the person performing the abortion is subject to imprisonment of 1 to 3 years. And there is an article 545 stipulates that a woman who has an abortion to save her honor would benefit from an attenuating excuse. Although the circumstances under which an abortion is considered to save one's honor are not stated in the Penal Code, they include various situations such as pregnancy among unmarried pregnant women and pregnancy resulting from rape. The benefit of an attenuating excuse also applies to the person contributing to an abortion in order to save the honor of a family member or a relative with or without the woman's consent. So abortion is criminalized. And there is a presidential decree dated in 1969 that reaffirms the prohibition of abortion, but modifies the penal code by permitting abortion if needed to save the pregnant woman's life. So it is a therapeutic abortion. Therapeutic abortions are currently allowed based on the conditions specified in Article 32 of Medical Ethics Law, number 288, dated 1994, February 1994, which indicates that the attending physician, before performing an abortion, must consult with 2 other physicians who have also performed a medical examination, and they all must agree that the woman's life can be saved only through an abortion. And so therefore, since 1969, there have been no attempts to expand the circumstances under which women can lawfully seek an abortion in Lebanon. Currently, there is no information on the number of legal and illegal abortions. And abortion is still not a public health issue of concern. The issue of abortion is not presented publicly as a reproductive right. It was not even on the agenda of the political parties or groups that run for the parliamentary elections that took place in May 2022. Abortion is discussed when there is a scandal related to it or a decision undertaken by the Ministry of Public Health to close a gynecologist clinic. So this is a little bit the context of abortion in Lebanon.
Thank you. Thank you very much, Dr. Zeina. Nargis, are you going to continue with some questions?
Yes, so thank you everyone for the introductory presentation. I want to continue with you, Dr. Zeina, and ask you about your work. You note that intersectionality, particularly in a sense whether a woman is married or unmarried, you also investigate religion and socioeconomic standing impacts the access to safe abortion for women in Lebanon. I wanted to ask you if you could elaborate on those and whether you've seen any contradictions between culture and religion in your work when it comes to terminating unwanted pregnancies.
Okay, so, my work was conducted within the context, my work on abortion was conducted within the context of my dissertation in 2011, Moral Work and the Construction of Abortion Networks, Health and Sexuality of Women in Lebanon. And in my work, I used a qualitative study in 5 provinces in Lebanon. Now they are 6, but at that time they were 5. And I collected data during a 6-year period from 2003 till 2008. And I used a double sociological approach. I relied on semi-structured face-to-face interviews. I conducted 199 semi-structured face-to-face interviews and also an ethnographic study. So I collected all stories, observations related to abortion during this period. And I used the grounded theory method I used the grounded theory methods. Participants, I recruited participants through personal networks that I have established during my years of work in the development sector, and also through snowballing. And the sample was like I did interviews with single women, 41 single women, and married women, 43. I also did interviews with partners, 28 physicians, 35 physicians, midwives, 15, pharmacists, 20, and allies, 15. And following, like I used Anselm Strauss' theory of negotiated order in order to analyze a little bit how the access to women to abortion services. So the decision to terminate the pregnancy is not predetermined, but rather the result of a negotiation between women and partners, between women and physicians, and where women and physicians, they create, maintain, and transform, they transform the discussions. And the negotiation is constrained by the illegality and social status of abortion. And so the right to safe abortion is a privilege rather than a right in the restrictive Lebanese context, since access to services hinges on a woman's social capital, networks, and ability to negotiate with partners and physicians. And single women from a disadvantaged socioeconomic background stand out as the most vulnerable. When it comes to intersectionality, like I took, in sampling the women who have had an abortion, I took the following factors into account, like marital status, married, unmarried, religion, Sunni, Shi'i, Druze, and Christian, geographic region, and socioeconomic background. And this allowed for an intersectional analysis of women's access to abortion. The most important attribute affecting the way women experience abortion is marital status. So the sample of single women included like different when we had single and unmarried and married. When we say single woman, it can be like divorced or a single woman or a person who did have the kitab but didn't move to the move to the with her partner, to live with her partner. So the common characteristic among all of them, like single of them, was that their single status put them in a vulnerable situation when seeking an illegal abortion, because their pregnancies, to many of them, their pregnancies were attached to stigma and sometimes to shame. And also the socioeconomic background, which was reinforced by an urban-rural divide, is an important determinant. Women with fewer economic resources are at higher risk of seeking a less safe abortion, knowing that in Lebanon, accessibility to abortion is feasible, to abortion services, access to abortion services is not like impossible, but at the same time, like the process is very difficult. Okay, to attain, to reach services. So marital status and socioeconomic background shape the possibility of accessing safe abortion care and the kinds of experiences women have. Yeah.
Thank you, Dr. Fathallah. And I'm already seeing some questions coming in about what you presented, so we'll keep those for the Q&A session. My second question was going to be to Dr. Samia. Dr. Samia, you already alluded to this slightly in your introduction, but in your paper, you discuss the concept of the heavy policing of maternity wards, that if a woman comes in unaccompanied, police may question her even while she receives care, or she's giving birth, or an unwanted pregnancy is being terminated. And you tie that with a concept of Hippocratic disobedience. I was wondering if you could tell us a little bit more about this and what does this look like in Sudan?
Okay, thank you. There is in the public hospitals, under the Islamic rule, there is a police for really monitoring the unmarried women who come for abortion. There is no problem with the married women because they can have the certificate, but the unmarried women, there is a police there. The police would come and have to check with the certificate. In case the women do not have, then the police would wait for them until they are given the care, and then they would be taken immediately to prison. Doctors, we discussed with them in our interviews, are not concerned about who is married and if the woman is married or not, and they give the care. And even if the police is not there, they would not report that this woman is married or not. And therefore, they would give the care whatever the situation, and that is why we say that they go against the policy of the government and they give the care whatever the situation. But therefore, the access to abortion for the unmarried girls, it is a matter of luck. If the police is there and he or she are monitoring, then they would be unlucky and they would be taken to prison. If not, they would be lucky because the doctors would give the care whatever the situation, and they would be lucky and they can escape. And usually, most of the doctors, they help. Even they help, I can't say, even, okay, thank you. I am under a military rule. I have to be very careful about what I am saying.
Thank you so much for that answer, Dr. Samia. And with a final primary question to Dr. Foster, you've covered a number of countries and the access in those countries varies significantly. I was wondering, in countries where abortion is more legally restricted, what kind of practices do you see?
Thanks so much for the question. And I think, we see a range of practices in the region. I'll talk a little bit about the UAE because I think it introduces some different strategies that people are using to access abortion care. And just as a point of grounding, in the UAE, abortion is only legally permissible to save the life of the woman, and the law is very narrowly interpreted. Both clinicians and women face criminal penalties for providing or procuring an abortion, and those criminal penalties are actually quite stiff and consistent with other laws governing behaviors. The UAE is somewhat exceptional in that the government in the UAE has actually instituted sting operations to try to find private sector abortion providers operating within the country. And that's something that we don't see in most other places in the world, even when abortion is heavily criminalized. And as a result, we have almost no population level information about what's happening with abortion in the UAE. It's too stigmatized, and there's incredible social stigma, but also this legality issue. But we know a couple of things about practices. And the first is that women with means, so often UAE citizens, typically engage in something called abortion tourism to be able to obtain their abortion care. And this involves leaving the country and going to a country where they can obtain care. European countries are the primary destination for abortion tourism for women who are living in the UAE. But increasingly, we actually also see women from the UAE going to Beirut to obtain private sector abortion care in Lebanon. And there's some irony here because, as we've heard, Lebanon actually also has a very restrictive abortion law, but there is private sector provision, particularly in Beirut. And if people have money, are able to access that through various kinds of networks. And we're actually seeing some low-grade advertising of these services through women's magazines and blogs. The other thing, though, that's happening in the UAE, which is consistent with what we see in a lot of the world where abortion is legally restricted, is that people who don't have the ability to travel, either they don't have the legal right to travel out of the country by themselves or unaccompanied, or because they don't have the means to do so. And so in the UAE context, that includes a lot of the non-citizenry expatriate workers who are there. Increasingly, we see people turning to global abortion telemedicine services. So there's two big services globally, Women on Web and Women Help Women. And both of these global telemedicine services will provide medication abortion drugs through a DHL package to people living in countries where abortion is legally restricted. And so the way that this works is if you have access to an internet-enabled device, you go online, you fill out a consultation form, and on the back end, somebody from one of these services reviews it. And if you're eligible, you'll get mifepristone and misoprostol sent to you in the mail, or information about how to use misoprostol alone. And we're seeing more and more of this coming, more and more requests coming out of the UAE. There are still legal risks that are associated with using global telemedicine services, but we don't have any evidence that women have been imprisoned for obtaining abortion care in this way. And so we're really starting to see more use of that modality. And then I'll also just say that, of course, like what happens around the world when abortion is legally restricted, we do see people using unsafe methods to self-induce an abortion. And that includes things like sharp stick insertion, pummel massage, using various kinds of drugs in self-injurious behavior. We do have documentation all of those behaviors as well. And again, that's consistent with what we see not only in the region, but in other parts of the world where abortion is legally restricted. The final thing I'll just say has, in this we are seeing much more of in countries like Egypt, Jordan, and Palestine. I'm happy to talk more about it if people have questions, is the use of a drug called misoprostol and using that drug alone to self-manage a medication abortion. And so this drug, which is widely available because it's used in for a lot of different obstetric and gynecological indications, including used for postpartum hemorrhage prevention and treatment. But because it's widely available, and there's a really rich history about this drug and how it became available in so many retail pharmacies around the world, but because this drug is available and can be used as a solo abortifacient, we're seeing more and more people using misoprostol alone in order to induce an abortion. And misoprostol alone is very safe and effective. And so we're starting to see some real shifts in the region about practices in contexts where there are legal restrictions.
Thank you. Thank you very much, Dr. Foster. Thank you, all of you. I mean, what is very apparent to me, and maybe not surprising, is that, of course, also in this context, intersectionality matters. I mean, class being probably the most obvious factor here. And I guess I would say that, again, the Middle East is not the only region and countries in the Middle East where even when there are strict rules and regulations, that with money that you have easier access. I mean, it doesn't mean that it's super easy, but, you know, either finding private clinics or, as you just mentioned, Dr. Foster, traveling, being able to access abortion elsewhere. So, I mean, I have many other questions, but I'm conscious also of our audience participation. So I suggest I'm just going to read those out, and then maybe we can get back to our questions. So Mala Hatun asked whether we could share the text of the presentations. I mean, that's not what we usually do, but a recording of this event will be available, and then you can look at it again and also circulate it to friends and colleagues. And there was a question about the practice of abortion in this context. I think we have covered quite a bit of this. And you also ask whether people cross national borders to see abortion, for example, from Lebanon to Israel. So we've already addressed that, but maybe either Zeina or Angel or Samia can say a little bit more about that. So then we have a question from Miriam Omar. She's asking a question to Dr. Zeina. Did your research touch on service providers' attitudes towards abortion? I'm from Libya, and even in cases when abortion is legal, in the context of threat to women's health or rape, service providers might refuse to provide abortion because of stigma and fear of prosecution. And I guess this is a question that we can actually ask all of you. I think that's interesting to reflect on this. And then I'm also going to share a question by my colleague and friend Martina Kamp, who's asking all panelists, how important are feminist organizations for the debate on reproductive rights and the autonomy of women? And is it important if these organizations are linked to international, transnational feminist organizations? Okay, so you know, I'm just going to ask everyone whichever question or questions you'd like to respond to. I'm going to ask Dr. Zeina to start us off, please.
Okay, so one of the questions was about do people cross Lebanon to occupied Palestine? You know, like the Israeli army has invaded Lebanon several times. It has destroyed Lebanon, many parts of Lebanon. It has built like prisons in Lebanon, Ansar prison. It has other prisons as well. So definitely people do not cross the border to occupied Palestine. This is as, yeah.
I was wondering if you can tell us as well a little bit about people crossing the border to Lebanon, and what does this look like? How do they negotiate? You mentioned negotiation is a big element.
People crossing from to Lebanon from which countries?
Say
like,
if they're traveling from other countries, maybe Jordan. Do you see that in your discussions?
Well, in my conversations with the healthcare professionals, it might, but it's rare. It might exist, but it's rare, depending on the conversation with the health professionals. Sometimes, like, you know, like in certain areas in Lebanon, in Hermel, Akkar, Hermel, like they are near the border, Syrian border. Maybe some people did cross the border to go to Syria. and to seek, because before it was like, before the conflict in Syria, some people did cross the border in order to seek medical, but I don't know. I need to have accurate information on this and check again.
Yeah, if I, sorry to interrupt, and we'll come back to you in a moment, Dr. Zeina, but I'm actually going to ask Dr. Foster, because you did mention this. Would you like to come in here?
Sure. I mean, we do see abortion tourism within the region, and then from people traveling from the region, again, primarily to Europe. And that's something that is, and I would say we have pretty good documentation of this happening prior to COVID-19. COVID-19 has changed and disrupted travel patterns overall, so there's definitely some shifts that have happened. But thinking about a kind of broader trajectory, we see abortion tourism that happens all over the world, where people travel from a country where abortion is more legally restricted to a country where abortion is less legally restricted, if they have the means to do that. And famously, that's true in Poland, and Polish women traveling to places like Germany. And prior to the liberalization of the abortion law, we saw women in Ireland who would travel to England to get abortion care. And similarly, we know that in countries, particularly the Gulf, that abortion tourism is a dynamic, again, for citizened populations that have the ability to travel. So moneyed populations that have the ability to cross national borders. And this issue of going to Lebanon, I think, is kind of fascinating. And this has something to do with the fact that there is this highly trained private sector abortion cadre of abortion providers that exist in Beirut, or that has existed in Beirut for some time, that are able to provide care through the private sector. And while that care may be technically illegal, or it is extra legal, the care itself is really safely done, because these are highly trained, mostly physicians, who are offering this care through private clinics. And that's where we see the most travel within the region. For a number of different reasons, we don't see as much travel from countries, for example, in the Maghreb to Tunisia, right? And I think a lot of that has to do with the fact that there are private sector providers in Tunisia of abortion care, and there is some intra-regional travel. But because so much abortion care lives within the public sector, it's different to try to access abortion care if you're not a resident of the country, or if you're only coming for a short period. And so I think that influences how it is that people access services.
Thank you. Thank you. So there are a number of other questions, and Dr. Zeina, I'm going to come back to you in a moment. But I would like to ask Dr. Samia now, because one question is about the attitude of providers. And I understood from your presentation, Dr. Samia, that generally speaking, doctors are very supportive. Can you say a little bit more about that? Hello.
Yeah, okay. We have to differentiate between pregnancy that comes as a result of the rape, and pregnancy for married women, or pregnancy that comes for a consensual sexual relationship. I would like to talk about raped women and girls. They are stigmatized from the first moment by their families, by their communities, by the police, and by the service providers. And therefore, their situation is very critical, and they may not, you see, they can get pregnant, they may not find access to services. But for the women who are well off, who have, who are privileged, they have no problem. Specifically if they are educated. So these are intersectionality, education, knowledge, and economic class. If they are well off, then they have no problem. They would not face this stigmatization, because they would go to private clinics. They know the services, they know their way. They can even get access to the misoprostol, because there are some private clinics which they can afford and can give them. The problem is the poor women, the low-class women. These are the most stigmatized women, and they are really, they don't find, even when they go to the police, because they have to have the report Form 8 for the rape, they may not finding. The health providers at the stage of reporting the rape may not really be willing to fill the form, because rape is always considered as the mistake of the woman. She is always blamed for it. And therefore, that is why she is badly treated at this stage. But when they have the complications of abortion and they go to the public hospitals, this is where doctors' behavior is different. The doctors we met, the doctor we interviewed, they say it, we are not concerned. We are concerned only of saving their lives. We are not there to police them or to punish them why they have become pregnant.
Yeah, thank you. Thank you. So I mean, I think that, I mean, we can't go there, but I mean, it seems also obvious that the specific attitudes towards abortion, I mean, the kind of taboo or stigma that's attached to it, but also the policies don't exist in a vacuum, but they exist within wider norms around gender and sexuality, as well as the kind of specific political culture, I guess, that exists. But I'd like to come back to Dr. Zeina to ask you about the attitude of providers. I mean, I assume that in Lebanon, you also have a range of different attitudes, and also depending on, you know, where, Beirut or the south. And I guess I'm also interested, do attitudes change if the woman is a Syrian refugee or Palestinian refugee? I mean, can you tell us a little bit about the attitudes of providers?
I interviewed, in my first study, I interviewed like 35 providers, doctors, and among them, like I interviewed people who do offer abortion services. So who the doctors who offer abortion services. And among these 35, so there are some doctors who are pro-choice and others who are pro-life. And those whom that I did interview, they do offer like services, and among them, like 35, 26 of them mentioned the term of fault, غلطة, it's a fault, okay? And it's related to a judgment over like the behavior, sexual behavior of the woman. It's not just about, it's not about getting pregnant, it's about like the sexual behavior. There is a proportion of doctors who do not, in Lebanon, like there is diversity of norms when it comes to sexuality. And and premarital sex is accepted by a certain group. The norms, some people tolerate premarital sex, others do not tolerate premarital sex. So it's not like there is heterogeneity concerning sexual practices. And the doctors, some doctors, for example, they say, they mentioned that it was a fault, and the woman has to recreate a new self in front of the doctor. Like she's not going to engage in premarital sex, or she's going to be more careful, or to use contraceptives. It depends on the negotiation with the doctor, the age of the woman. So, but also when it comes to a social class, some doctors, for example, in rural areas, they are supportive when, for example, a married woman would like to have an abortion, and she has children. They do understand the financial constraint that is being put, the burden being put on women. So they do the operation, they perform the operation. Also, for example, if a woman has been like certain doctors, for example, if they know that the woman is going to be stigmatized, and not only, especially in the certain rural areas, if the woman is going to be stigmatized and she's not going to, they explain that it's not only her who is going to be stigmatized, all her family is going to be stigmatized. Maybe her sister is going to her married sister will have a divorce because of the stigmatization that would like taint the whole family. But yes, some doctors do understand the situation of women, and they are supportive. Especially, they do understand the social constraints and the norms existing. But we have to keep in mind that norms are not rigid; they are constantly changing in Lebanon, and at the same time, it's not one single norm that is operating on everyone. And even people have different discourses depending on their, for example, primary groups, okay, how they present themselves to different groups.
Yes.
So,
yeah, I think that's a really good point. So my colleague Maya Mekdashi wrote this excellent book about the intersections between sectarianism and gender norms, and she calls it sextarianism, and I think that's a really good term. So Nargis, did you want to pursue question about feminist organizations?
Yes, so Martina Camp in the Q&A is also asking, how important are feminist organizations in the context of this debate and autonomy of women? And is it important, or what importance do you place on the organizations being international or transnational? I also want to ask add to this. Is it important and is it feasible that these organizations are based in the countries that they operate or they lobby? Sometimes we see that as an important aspect, and I would like to ask about your opinions. I was wondering if you could start with you, Dr. Foster.
Sure. I'll say that there's a lot of in my experience, there's a lot of variability. There has been, and I will say this really sort of started in earnest after the revolution in Tunisia, feminist activist who's a physician and one of the leaders in abortion care founded an organization called Tawhida Ben Sheikh that is really oriented a feminist model of how to preserve reproductive rights in Tunisia, and has done a lot of work within the region with other feminist groups in terms of training around abortion, doing values clarification around abortion, and then advocacy around abortion. We see some great feminist activism that's coming out of Lebanon as well. And I'll say that, you know, that some of those groups are very much in conversation with kind of the global movement around reproductive health rights and justice, but are operating very much within specific country and regional context. And I think a lot of the intra-regional exchange and mobilization has been really powerful. I think there are other countries, though, in the region where feminist activism has not been as oriented around abortion. And for example, I do a lot of work in Jordan, and again, abortion has not been nearly as visible within the overarching sort of feminist mobilization around other gender rights issues. And I think there's a lot of reasons for that, but so I think you see a lot of variability. I think what we also see, though, in much of the region, and this is somewhat different from what we see in other parts of the world, is the importance of professional medical societies and physician groups in their work around abortion care as well. And that, I think there's plenty of scholarship that has looked at the social power and networking of physicians within the region. And in this space, that there's a lot of, they have a lot of import as well.
And I was wondering, Dr. Samia, what are your thoughts on the presence of feminist organizations?
Okay, thank you. I just want to say that after being for 30 years under the Islamist military rule, we have been just resisting the military rule, and we have not talked about feminism because we were not, there was no space for us to move and to really have a feminist movement. But after the revolution, after 2019, we are there. Women activism is really very effective, but we are divided. And there is now a problem in the women activists between the young and the old generation, because the older generation are very conservative, and there is a stereotyping feminism, and therefore they want to stick to be as women movement and not feminist. And this is this is a very serious issue for many feminists, because that means they are not going to talk about sexual and reproductive rights. And this is really a problem. But the young women are now identifying themselves as feminists. They are there, they are in the public space until 2021, because now we have another military rule, and it is really putting a lot of pressure. But their voices are very high. They are talking about their sexual rights. We have now a group of LGBTQ coming out, and their voices are heard, but they are not really, their voices are not heard even by the women activists, you see. And because the women activists many activists are still very conservative. And therefore, the question is that, can we talk about abortion with these young women? I say yes, they already talk about abortion. We had 2 or 3 sessions with them on our paper on abortion, but it's very difficult to talk about older women about sexual rights. We had a Bill of Rights where we put this right to abortion, about sexual rights and this, and it was refused by one of the very big coalitions in Sudan. They said, no, this is too much. It will cause us a lot of problems, and this is not its time now. So what we are doing now is that we are working to strengthen our feminist understanding, feminist commitment, and feminist activism. And we are going well, but I hope that the next generation, younger generation, may be stronger than us, and they may really one day be very vocal and have loud voices on abortion and on their sexual rights. Thank you.
Dr. Zeina, I was wondering if you had any thoughts on the same.
Well, we have like human rights associations in Lebanon, and they are very active. There is a diversity of organizations. They have a lot of, like, they tackle many issues, like, for example, protecting women against the gender-based violence. They have to advocate for the rights of Lebanese women to grant their nationality to their children and foreign husbands. And they have to address also the flaws of the they do address the flaws of the personal status law. So we have many many feminist associations and associations that address women's rights. They are very active, especially after the 2019 uprising in Lebanon that took place in Lebanon. They had visibility. They were very active, and yeah. Still, reproductive rights are being on their agenda. Reproductive rights are being talked about. Yeah.
Yeah, that reminds me. I mean, when I did my PhD on the Egyptian women's movement in the mid-90s, I mean, at the time, reproductive rights were being talked about, but I do very much see this point that Dr. Samia made about the generational shifts, because I do think that while there are obviously specificities in each country, and, you know, in Lebanon, you know, there is much more of a sort of history of feminist movement that addresses issues around sexuality. We even have queer activists, but generally speaking, I mean, when I did my research in the 90s, I think across the region, there was this hesitancy to use the term feminism very much associated with the West, but that has changed a lot amongst the younger generation that is much more sort of confident in appropriating the term. And as, you know, Egyptian young feminists told me, well, we don't need a Western feminist to tell us about women's rights. But I'm going to ask Nargis to ask the next question. I mean, one of the things that I was wondering about as I'm listening to you is the relationship between abortion and access to contraception. And I was wondering if we could address that as well. But Nargis, did you want to follow up with another question as well?
I think that's the perfect question to pass to the panelists. And I could ask, there is one that I have on my mind, but I'll keep it after this one. How do you see the relationship between access to abortion and access to contraception changing? Or how is it currently as well? Oh, I'll start us off with Dr. Samia.
Okay, yeah, thank you. This is a very important question because, again, with the Islamist rule, they have really, they're very conservative in relation to contraceptives. And although we have UNFPA, which they provide us with lots of contraceptives, but what the religious messages and discourses are saying, it is against the use of the contraceptives. And therefore, it's not really widely used. This is one of the issues. There is a lot of contraceptives, but there is no awareness of its use. That's why we still have a very high fertility rate. And that is why young women cannot really protect themselves by using contraceptives. Some pharmacies even stereotype young girls who come and ask about contraceptives. And this is really a problem because this is the mindset of the Islamists. Why a young 17 years old girl come to ask for contraceptives and she looks unmarried. So this is relates also to these girls have no alternatives. They go and they get pregnant, and so they are at risk of unsafe abortion. So we have also a problem of contraceptives, very high unmet need for contraceptive. And because of this religious message and discourse, which is still going on. So the two problems are related until we get our civil government, until we get our democratic government, we will be struggling in different on different issues, in different paths. And we are hoping, we are still hoping.
I think before I pass it over to Dr. Foster to explore this question as well, I would like to highlight that this difference varies with the interpretations of Islam. And some countries are more flexible in their interpretation, more flexible in access to contraception for both married and unmarried women, and how they view fertility in relation to Islam as well. And so we will see this access varying. We will see this allowance, or we will see the religious scholars' encouragement varying by the government, varying by their interpretation of Islam. And I know, Dr. Foster, you discuss Egypt a little bit in your book. I was wondering if you can talk to us, not just Egypt, how do you see access to contraception relating to access to abortion in your work?
Well, so first, and obviously the region is quite diverse, but one of the things that is true for many of the countries in the region, particularly when we think about North Africa, Egypt, Levant countries, is that there's a long history of having national family planning programs. Now, those national family planning programs have historically targeted married women of reproductive age and have excluded unmarried populations. And in almost all cases, they don't include abortion care as part of the core national family planning program. Here I will say Tunisia is truly exceptional on both fronts. There's both services in the National Family Planning Program through the ONFP that provide abortion care, but also services for unmarried women or unmarried and youth populations. So I think that, we do see, so we have these national family planning programs that have not incorporated abortion sort of in earnest in most of the region, which means there is this real separation between contraception and abortion. So we don't have as much sort of comprehensive reproductive care being provided through public sectors. To your point about, obviously there's a lot of, we could have a lot of discussion about Sunni Islamic jurisprudence and sort of the history of the permissibility of contraception within the marital relationship, there is quite a long and robust history of religious permissibility of non-permanent methods of contraception in a marital, in an illicit or marital relationship, and that is really that's really undergirded a lot of these national family planning programs, and it's why many of these programs have quite significant contraceptive method mixes. And so we see, for example, not only hormonal contraceptive methods, but also longstanding use of the intrauterine device as part of these methods, as part of the program. Having said all of that, and there's certainly room to improve contraceptive service delivery in the region, absolutely more work for unmarried populations, all of that's very important. There is always a need for abortion. So even with the most robust, comprehensive family contraceptive service delivery program, there's still going to be contraceptive failure. There's still likely going to be unmet need, and there's still going to be unwanted, unintended pregnancies, and therefore people will need abortion care. So while there is a relationship between those two things, it is not that improving contraception will eliminate the need for abortion. That it can reduce the unintended pregnancy rate, which is why we see a relatively low abortion rate in Tunisia, for example. It's because the unintended pregnancy rate is relatively low, contraceptive prevalence is high, but we still need access to safe abortion care, even in the most robust contraceptive settings.
Thank
you. You're muted, Nargis.
I thought I unmuted myself. Dr. Fathallah, I was wondering, how do you see this access between the relationship between access to contraception and abortion?
Yes, definitely. As Dr. Angel said, that basically, even if there is contraception, it doesn't mean that there wouldn't be like a need for abortion services. That it will decrease maybe, but there will still be a need for abortion services. In Lebanon, I think like contraceptives, we have to look at the cost of contraceptives. Definitely there is like a program that is being undertaken by the UNFPA and the Ministry of Public Health concerning like reproductive health services within different primary health centers and the dispensaries. But at the same time, like if you go to a pharmacy, the cost has increased, and people, for example, who do not want to go through to primary health services, if they have to go to pharmacies, the costs have increased during the economic crisis. So availability due to the financial constraint, availability of contraceptives has decreased. Yeah.
Yeah, well, thank you all for your insights. We are shortly running out of time, but I think we can look to at least one more question. I see there's another one here from our audience. Mariam Omar is asking all of you, in your opinion, what are the main barriers to conducting research? So, okay, yes, Dr. Foster, would you like to start us off?
Sure. I find this question challenging because as a global abortion researcher, there are things that are challenging about doing research in the abortion field, but abortion is the reality for so many people around the world that I haven't found it particularly challenging to do research around abortion. And I will say the place where I found it the most challenging to do research around abortion has actually been the United States, because of the overarching political context, funding restrictions. So that is actually, to me, a much more challenging environment than doing work around abortion in the region. Having said that, we're talking about issues that, address stigma, illegality sometimes in certain contexts that can involve, that are tied with, gender rights that are tied up with sex and sexuality. And so there can be a lot of sensitivities. And so I think, we have to be responsive to that. But I actually would like to leave with the message that it actually is very possible to do this work in the region. I think sometimes if you're new to the abortion field, one of the ways to do that is to think about incorporating abortion into broader kinds of discussions around women's health, around family planning, around reproductive health, so that it's not solely abortion focused, because that can be easier inroads. But I would say overall, my experience doing work on abortion in the region has been very, very positive.
Yeah, thank you. I mean, I'm not surprised about your experience in the context of the United States. And I think that's where we, sort of counter the preconceived notions about, Middle East and the US and so on. Yes. So, Dr. Samia, would you like to say something to this question?
Yes, I just say that researching abortion is very difficult, and I agree that we have to put it in a different context. I did the research in 2000 on maternal health, and a lot of information came on abortion, and I never published that research because the security would not leave me. It will not leave it will really be harsh on the university students where I did the research. And therefore, it's not easy to research abortion because it is stigmatized, but we can go around and talk about reproductive health and this. The Ministry of Health cannot give us any information. And maybe the practitioners themselves, they may not be willing to talk because our environment is a very bit complicated. Security-wise, we are all insecure. And therefore, we did this research with a lot of insecurity. And because we went through our relationship, we didn't find ethical clearance from the ministry. And so in our situation, it's different. It's very difficult because the conservative Islamists are there. They are there after the coup, and therefore, in our situation, it's not easy. And I wouldn't attempt to do research soon on abortion, but maybe until we wait until our situation changes. This is one issue related to the policies and government and politicians. But even socially, it may not be easy. We cannot go to families, we cannot go to women and ask them about it. We have also to go roundabout because it is a stigmatized issue. It is a taboo issue. Thank you.
Yeah, thank you. Dr. Zeina, would you like to address this question?
Yes, well, it's not impossible to do a research on abortion, but at the same time, having access to the field as a researcher is not an easy. Also, it's not easy. You have for example, in order to do my study on abortion, I used to work first as a health education specialist in a joint program between the UNFPA and the Ministry of Public Health. And based on my network and the trust relationships that I had with the healthcare providers and women, I have been able to have some feedback from women and conversations with women and healthcare providers. But the relationship of trust has to be present. It has entering the field is not collecting data, having access, being able to talk to people is not easy to achieve, but it is possible. Definitely, it is possible.
Yeah.
Right now, for example, I'm doing again a study, not as not on a larger scale, but I'm trying to interview women. Like a sample, I'm trying to interview women on their experiences, and my sample is 20 to 25 women. It's very hard to get back to the field. It's very hard to be able to talk to people, to build again relationships of trust.
Yes.
Yeah.
Yeah. Thank you very much. I mean, unfortunately, we have to close very soon. But as I'm listening to you, you know, discuss the various context and obstacles are legal, whether they are linked to social stigma, whether they're linked to health. I mean, I'm acutely reminded of the fact that we haven't even touched on war and conflict and displacement. And these are, of course, huge issues in the region. I mean, I'm most familiar with the Iraqi context, and there, I mean, access to reproductive health care has changed radically in light. And I think, I mean, that was true for many countries in the region, and displacement is another huge issue. But we've covered lots of ground. I have learned a lot from all of you. I'd like to thank you very much. I would like to thank Nargis for, you know, really sort of spearheading this effort, and I've learned. The event will be available in a couple of weeks. We'll make it available, and then you can rewatch or share with friends and colleagues. And so I'd just like to thank you, all of you, for participating and for sharing your insights. Thank you very much.